Hear me?
I can hear you.
Okay. Okay. Assalamu alaikum everyone once again. My name is Rajiv Yusuf, and today I'll be presenting a case on diabetic nephropathy. And this case was prepared together with Ahmed. I'll go right ahead to the biodata. Our patient is called CK. Okay, our patient is called CK.
Sì, va qua alla stretta. Io tengo la cazzo, un mese.
I'll start now for the biodata. Our patient for today is CK, a 49-year-old male from Kasarani who works as a real estate agent and was admitted to KNH 2 weeks ago. CK is a non-diabetic patient who was diagnosed at Kenyatta 10 years ago and has been on follow-up at a health center in Kasarani and was started on metformin 2 years ago, but has been non-compliant because of lack of knowledge about the consequences of not taking his medication regularly. He's also a non-hypertensive patient diagnosed 10 months ago at KNH and has been compliant on nifedipine and atenolol. With PC, the patient presented with leg swelling for the past 1 month, shortness of breath for the past 2 weeks, and abdominal pain for the past 2 weeks. For his HPI, the patient was in fair general condition until 1 month ago when he developed bilateral leg swelling from the foot to just below the knee, which was gradual in onset. It was constant, progressive, and was associated with limb weakness bilaterally. It was sharp. It was also associated with sharp non-radiating pain precipitated by walking, darkening of the skin, early morning facial puffiness that will reduce as the day progressed, and generalized abdominal distension. There was no associated warmth or coolness. There was no numbness. There was no paresthesia, hair loss, or shininess. His leg swelling was aggravated by prolonged standing and was relieved by limb elevation, and it was severe enough to affect his activities of daily living. The patient also reported to have had decreased urine volume, but he had increased frequency to around, he reported to have had around 7, to be voiding around 7 times per day. He also had urgency and nocturia, which he reported to be around 4 to 6 times per night. There was no hematuria, dysuria, urine color change, incontinence, flank pain, fever, or rigor. There was also no terminal dribbling, hesitancy, or slow stream. The patient also had shortness of breath for 2 weeks, which was gradual in onset, progressively worsened to New York Heart Association +3, and was associated with easy fatigability and palpitations, but there was no PND, orthopnea, platypnea, or chest pain, night sweats, weight loss, wheezing, dizziness, or syncope. It was aggravated by exertion and relieved by rest. The patient also presented with abdominal pain for 2 weeks that was initially localized in the suprapubic area. It was gradual in onset, sharp in nature, and radiated to the epigastric region. It was associated with the abdominal pain was associated with postprandial vomiting that was bilious. It was non-projectile and mostly had food content with no blood, and his abdominal pain was aggravated by feeding and relieved by paracetamol. The patient had decreased appetite, early satiety, constipation, bloating, flatulence, but there was no dysphagia, odynophagia, diarrhea, yellowness of the eyes, or pruritus. The patient also had reported to have had loss of consciousness, which lasted for around 5 minutes, and together with confusion, but there was no headache, convulsions, changes in speech, sensation, body weakness, or loss of bladder or bowel control, and there was also no memory loss. The patient also had an episode of nose bleeding that lasted a few minutes, but and stopped on its own. He also had streaks of bright red blood mixed with stool. There was no hematemesis, melena, or easy bruising. He denies smoking but has been drinking alcohol for the past 31 years. And he reports to have been drinking 3 to 5 bottles of beer per day, each around uh, each around 500 ml. And he also had regularly will drink illicit brew. He usually feeds on a mixed diet, which consists mostly of vegetables, meat, and grains. He doesn't take sugary foods like cakes, and he restricts his salt and fat intake. There's also no history of diabetes, hypertension, or malignancy in the family. With diabetic history, the patient was diagnosed with type 2 diabetes 10 years ago at KNH and has been on follow-up at a dispensary in Kasarani. He has been on metformin for the past 2 years, but reports non-compliance because of hypoglycemia and lack of knowledge. He has not experienced any major side effects from metformin. He has not been monitoring his sugar levels regularly and has been unaware of his HbA1c percentage. But on admission 2 weeks ago, his sugar level was 26 millimoles. He adheres to a healthy, well-balanced mixed diet, but has not been exercising regularly. There's no history of limb pain on walking, no history of focal neurological deficits or chest pain that radiates to the jaw, neck, shoulder, or left forearm. However, he reports bilateral foot ulceration involving all the toes after wearing ill-fitting shoes for the past, and it has been there for the past 1 month. For the ulcer, he has been taking care of it at home with soap and water. He also had visual disturbances with temporary blindness for 1 week about 2 years ago. However, he has never experienced erectile dysfunction.
Rajiv, we can't hear you.
How about now?
We can't hear you now.
What is the last part you had?
Just the last like 10 seconds.
10 seconds.
Yes.
Okay. The patient reported to have had visual disturbances with temporary blindness which lasted for about 1 week, about 2 years ago. However, he has never had erectile dysfunction, urinary incontinence, or diarrhea. Past medical and surgical history. There is no past admissions for any other problems. He has no known food or drug allergies, no history of blood transfusion, no history of surgery. And apart from diabetes and hypertension, he reports no chronic illnesses such as cancer and tuberculosis. There's also no history of fractures or trauma. Family social history. Our patient is married with 3 children, all of whom are healthy. He works as a real estate agent in Kasarani and he has active HIV cover. There's no history of chronic illnesses such as diabetes mellitus or cancer, and there's also no history of sudden death in the family. Systemic review at the time of clerking and review of his CNS system. There was no headache, visual disturbance, or convulsion. Musculoskeletal system, there was no myalgia, no arthralgia, no bone pain. Cutaneous, there's no rash, bruising, or any skin color changes. Genitourinary tract, there's no dysuria, no hematuria, no flank pain. GIT, there's no abdominal pain, hematochezia, or melena. In summary, I'm presenting CK, a 49-year-old male from Kasarani, who is a non-diabetic patient for the past 10 years, has been non-compliant on medication due to lack of knowledge about the consequences of not taking his medications regularly. He's also a non-hypertensive, diagnosed 10 months ago. He presented with 1 month history of bilateral limb swelling associated with early morning facial puffiness and abdominal swelling. and a 2-week history of progressive difficulty in breathing and epigastric pain. He reported decreased urine volume, but increased frequency and nocturia. There is no history of PND, orthopnea, dysuria, hematuria, or fever. General exam, our patient was a middle-aged African man who was in fair general condition, and at the time of clocking, he was lying supine. He was fully alert and oriented in time, place, and person. He had normal hair distribution. There was no obvious sign. There were no obvious signs of respiratory distress or wasting. His vitals, his BP was 148 over 78, taken in seated position. Pulse rate was 88, temperature was 36.5, respirator was 16, his SpO2 was 96% on room air, and he had edema and pallor, but there was no jaundice, cyanosis, clubbing, lymphadenopathy, or dehydration. Systemic examination, CVS exam, his pulse was of normal rate, rhythm, volume, and character, and there was no radio delay or radiofemoral delay. On inspection, there was symmetrical chest, moving the respiration, normal active precordium. He had a central line in situ. JVP was normal, and there was no distended neck veins, no scars or deformities. On palpation, his trachea was centrally placed. His apex beat was palpable in the fifth intercostal space mid-clavicular line, and there were no heaves or thrills palpable. On auscultation, S1 and S2 were hard, and there were no murmurs. On respiratory exam, inspection, symmetrical chest and moving the respiration. On palpation, the trachea was centrally placed, and there was normal vocal perimeters. Percussion, his chest was resonant bilaterally. Auscultation, there was good bilateral air entry. However, he had fine crepitations on the lung bases bilaterally, and he had vesicular breath sounds. Abdominal exam on inspection, his abdomen was symmetrical and it was distended. There was movement with respiration. However, there were no scars or superficial dilated veins or any masses visible. On palpation, there was tenderness at the epigastric region and the right hypochondrium. However, there was no obvious splenomegaly or hepatomegaly. On percussion, the patient had shifting dullness and fluid thrill, and the liver span was 8 centimeters. On auscultation, patient had normal bowel sounds, and there was no bruit. CNS exam, his DCS was 15 over 15. There was no focal motor deficits, and his sensory system was also intact. And also all his cranial nerves were intact. Lower limb exam was progressive darkening of the feet, and there was noted drying, fissuring of the feet, and he had a bilateral ulcer on the hallux. The ulcer on the right measured 3 centimeters by 4 centimeters. It was dry and fissuring, and also had an erythematous base. The ulcer on the left measured 1.5 centimeters by 0.5 centimeters. It was dry. His nails were dystrophic, and there were signs of interdigital fungal infection on the left foot. His pulse and sensation were also intact. Depression, diabetic nephropathy, hypertensive nephropathy, uremic syndrome, and diabetic foot. The following investigations were done. CBC, his RBC was 2.41, which is low, considering the normal range at KNH is 3.8 to 4.8. His HbA was also low at 6.7. Hematocrit was low at 21.2%. Platelet, WBC, MCV, MCH, MHCH were all normal. UECs, his urea was 11.21, which is high. Creatinine was 897.6, which is also high, and his sodium, potassium, chloride levels were normal. GFR was 6 ml per minute, which was low, considering the lower limit of normal is 60. HbA1c was 7.5, which was high, and his lipid profile was normal. An echo was done, and the following results were given. The patient had hypertensive heart disease with good biventricular systolic function and left ventricular ejection fraction of 62%. Type 2, left ventricular diastolic dysfunction and concentric left ventricular hypertrophy. Thank you. Then you can take over now.
Thank you very much, Rajiv. Doc, are we going to critique the history or do we move on to the next session? We have Rukia presenting a few slides on diabetic nephropathy.
Can I just say a few words? I'm driving, so I might not be very clear.
Okay, we can hear you though.
Okay, so very good, very detailed history. Only challenge when you mention you should avoid abbreviations like HPI or TND. Try and mention the full, like say history of present illness or paroxysmal nocturnal dyspnea. Some people don't know what the abbreviations mean, but otherwise very good history. One thing I would have liked to see or to hear that might have been mentioned, but I might not have heard it, is your fundoscopy findings. This is a long-standing diabetic with clearly chronic complications. I'd like to know what you found on fundoscopy. And the other thing, which now that you've done your lab, do you want to give us your diagnosis with the lab report? With you, do you want to change or do you want to be more focused in your diagnosis? Yeah, so that's the comment that I'd like to make.
Dr. Sokwala?
Yeah, I think let's go ahead and see what else you have, and then we'll just dissect each and everything what was presented, from the history to the diagnosis.
Okay, hi, perfect. Rukia, you can go ahead and present you can share your screen.
Assalamu alaikum, everyone. My name is Ruqia Mahat. I'm a level 4 medical student, and I'll be going through diabetes and its complications. I am kindly confirming if you can see my screen.
We can see your screen.
Okay. So I'll be going through diabetes and its complications, but first, a bit of physiology. So there's certain hormones that are involved in the regulation of blood glucose. So there's insulin. So insulin is going to be secreted by the pancreatic beta cells as a pre-proinsulin that is going to be cleaved to proinsulin, which is then stored in vesicles. And then it's cleaved into insulin. And then it starts doing its functions, whereby it promotes glucose uptake in the muscle, the adipose, as well as the liver cells. It also promotes glycolysis, glycogenolysis, as well as triglyceride synthesis. The counter-regulatory hormones for insulin would be glucagon. So this is secreted by the pancreatic alpha cells, and it mainly acts on the liver, where it's going to stimulate glycogenolysis and gluconeogenesis whenever there is low blood glucose, right? And then there's also adrenaline that's going to be produced by the adrenal medulla, and it's going to activate glycogenolysis in muscle and the liver, and it's also going to stimulate adipocyte lipolysis, and it has a direct inhibitory effect on insulin. Cortisol, which is produced by the adrenal cortex in response to ACTH, is going to promote protein catabolism in order to provide substrate for gluconeogenesis. And then there's growth hormone that's going to promote lipolysis, there is somatostatin that's going to inhibit the release of both insulin and glucagon. And there's thyroxine that's known to stimulate glycogenolysis. So what happens in diabetes is that the body has trouble moving glucose from the blood into the cells. So that's going to lead to an increase in the levels of glucose in the blood, and not enough of it that's going to go in the cells. So there's different types. There's the type 1, which is the insulin-dependent diabetes mellitus, and it's an autoimmune problem. It's usually seen in young individuals. The individuals are usually lean compared to the type 2 patients who are obese. So it's less common compared to the type 2. And with this, what happens is that there is autoimmune destruction of the pancreatic beta cells, and these individuals don't produce insulin. And because they don't produce insulin at all, their body has to find other forms of fuel sources. So the fat cells are going to start breaking down free fatty. The fat cells are going to break down into free fatty acids, and after that, the liver is going to turn the free fatty acids into the ketone bodies that are going to be used as a source of fuel. So the downside of that is that these individuals can get a complication known as diabetic ketoacidosis, whereby they get metabolic derangement. So they get metabolic acidosis, they can get problems with their potassium, hypokalemia. So as well as they can present with nausea, vomiting, as well as altered mental status, right? Then there's the type 2, which is usually seen, which is the more common type, and it's usually seen in obese patients. And these individuals don't have a problem with their insulin. Their problem is now the cells can't uptake insulin for one reason or another. The cells are resistant to insulin. So these individuals are more likely to get a complication called hyperosmolar hypoglycemic state, whereby the osmotically active glucose that's in the blood ends up pulling water into the blood. So they end up losing water, and so they get dehydrated. And because of that dehydration, they can end up getting, especially like if it's they can end up getting confusion and altered mental status. So it's usually seen in obese patients, it's usually seen in people who don't exercise, or in hypertensive patients. Then there's the gestational diabetes. So it's seen in pregnant ladies. So here you have, when there's during pregnancy, the hormones that are produced by the placenta are anti-insulinic. So they prevent the release of insulin. So some of these hormones are like something like human placental lactogen is going to prevent the release of insulin. So these individuals are more likely to get gestational diabetes. So some of the risk factors that the gestational diabetes are, if there's a family history of diabetes in a first degree relative, or if the individuals are obese, or if there's advanced maternal age. And then there's also drugs or chemically induced diabetes, as well as endocrinopathies, like a glucagonoma. Okay, so the clinical features, these individuals would present with polyuria. So because glucose is an osmotically active molecule, it's going to pull water into the blood it's going to pull water from the cells into the blood. So these individuals are going to they're going to present with polyuria, and because they're losing a lot of water, they're going to present with polydipsia, which is an excessive thirst. Polyphagia would result because there's alternative, there's no enough, polyphagia would present because there's no, the cells are being starved of glucose, and glucose is the main fuel in the body. And then there's also nocturnal enuresis, and it's usually the first sign in children. And then they'll be fatigued, as well as weight loss, because we know that there's going to be breakdown of proteins, there's going to be breakdown of fats. So as a result, these individuals are going to experience weight loss. And then fruity breath, because in, for example, diabetic ketoacidosis, there's the acetone. So the acetone is going to give a fruity breath. Onto the complications. The complications can occur in patients who have long-standing diabetes, and they can be classified as macrovascular complications and microvascular complications. So in the macrovascular complication, there's the coronary artery disease. So there's what happens is that there's going to be pathologic atherosclerotic changes that's going to happen in the coronary vessels, right? So that's going to decrease the blood supply, and that could ultimately lead to an MI. For a stroke, these individuals, because there's hypoperfusion of the brain, they can present with foconeurological deficits that can range anywhere from unilateral weakness, numbness, speech disturbances, etc. Onto the microvascular complications, where I'll spend a bit of time. There's the diabetic nephropathy, which our patient had, diabetic retinopathy, diabetic neuropathy, and the diabetic foot. So diabetic retinopathy, just a bit of statistics, after about 15 years with the disease, approximately 90% of the patients who have type 1 diabetes and approximately 25 of those with type 2 diabetes develop diabetic retinopathy. And how this happens is that it can either happen in a there can either be a non-proliferative retinopathy or a proliferative retinopathy. So the non-proliferative one, it's usually seen in earlier in the disease. So you have retinal vessel microangiopathy. So there's going to be blood leaking. Then there's going to be retinal hemorrhage, as well as infiltration with fluid leading to macular edema. So the vision loss in the non-proliferative one is going to be mainly because of the vision loss. Whereas in the proliferative one, there's going to be, because again, there's the retinal vessel microangiopathy, there's going to be chronic retinal hypoxia. And as a coping mechanism, there's going to be abnormal proliferation of the blood vessels. And that's going to eventually lead to, may potentially even lead to retinal detachment. And so the vision loss in the proliferative retinopathy is due to retinal detachment. The clinical features are, it's usually asymptomatic till the late stages of the disease. Patients can present with blurred vision, dark or empty areas in the vision, as well as visual impairment that may progress to blindness. And our patient also had some sort of decreased visual acuity, and he lost his vision for a week. Onto the diabetic neuropathy. So what happens here is that the chronic hyperglycemia is going to cause glycation of the axon protein, and that's going to lead to sensory motor neuropathy. So the clinical features, the early ones would be progressive symmetric loss of sensation in the distal lower extremities in a stocking glove pattern. So it should start in the distal areas as it progresses towards the proximal parts. There can also be burning feet. In the late stages of the disease, patients may complain of pain at rest and at night, decreased pain perception, motor weakness, as well as areflexia. Diabetic foot. So it can be classified into two, either a neuropathic diabetic foot or an ischemic diabetic foot. So a neuropathic diabetic foot, it's diabetic induced peripheral neuropathy. So there's going to be distal sensory loss as well as a burning sensation. Patients are going to complain of weakness. And of note to mention is that when you do physical exam of a neuropathic diabetic foot, the foot is going to be warm. It's going to have a pulse compared to now an ischemic diabetic foot. And it's also going to be, the skin is also going to be dry. Whereas in the ischemic diabetic foot, it's a diabetic induced peripheral artery disease. So in peripheral artery disease, we've already said that there's atherosclerotic plaque that's going to cause luminal narrowing of the vessels, right? And that's going to lead to a decrease in tissue perfusion. So you're going to, on physical exam now, the foot pulses are not going to be palpable. And the foot is going to be cool and pale as well, because it's not getting any blood supply. So the clinical features of a diabetic foot would be recurrent foot infections, like athlete's foot, cellulitis, a painless neuropathic ulcer on the plantar pressure points of the foot, of which our patient had, and foot deformities like a hammer toe. So a complication of diabetic foot would be now, because if there is secondary infection of that ulcer, it can lead to cellulitis, acute or chronic, osteomyelitis as well. That's why it's paramount to do a good diabetic exam, a diabetic foot exam. Onto what our patient has, diabetic nephropathy. It's seen in patients who had diabetes for 10 years. And the pathophysiology, how it happens is that because of that chronic hyperglycemia, it's going to result in an enzymatic glycosylation of the vascular basement membrane. And what this means is that glucose is going to be fixed onto the vascular basement membrane in the absence of an enzyme, right? So that's going to cause the basement membrane to lose its integrity. So it's going to become leaky, and you have proteins leaking into the wall of the blood vessel. And together with those proteins, there can also be macrophages as well as foam cells, which are basically fat-laden macrophages that are going to slip into the damaged glomerulus, and are going to start producing growth factors like transforming growth factor beta-1. And that's going to cause now the mesangial cells to regress to their immature form, the mesangioblasts, that are going to secrete more and more structural matrix. And that's going to lead to sclerosis over time. And that's going to diminish the nephron's ability to filter the blood. In addition to that, there is also hyaline arteriolosclerosis that happens. And it's going to result in decrease in the caliber of the lumen because of the deposition of this protein, right? So the efferent arteriole is usually more affected than the afferent arteriole. So as a result, there's going to be hyperfiltration at the glomerulus, right? So there's it's going to present as microalbuminuria, and this may progress to nephrotic syndrome, and nephrotic syndrome may potentially progress to chronic kidney disease, or even, yeah. The clinical features, it's often asymptomatic, but the patients may present with signs of nephrotic syndrome, like edema, because we've already established that these individuals are losing a lot of proteins in the urine. There's proteinuria, so there's going to be less oncotic pressure. So blood is, you have fluid moving from the blood and into the interstitial spaces, and that's how edema results. There's also going to be hypoalbuminemia, because these individuals are losing albumin. And because there is hypoalbuminemia, the liver is going to try and compensate for that by producing lipoproteins. And that's why there'd be hyperlipidemia as well. The mechanism is not really completely understood, but whenever there is low protein or whenever there is low albumin, the liver is going to produce lipoproteins. So that would result in hyperlipidemia. There would also be hypercoagulability, because these individuals are losing antithrombin 3, and we know that antithrombin 3, it breaks down thrombin. So if it's not there, it's going to be hypercoagulation, right? And then there is also hypogammaglobulinemia, because in addition to the albumin, they're also losing gamma globulins. So these individuals are more likely, they're susceptible to getting an infection, and so on and so forth. Patients may also present with signs of renal failure that we will delve into in a minute. On to chronic kidney disease. So it's defined as a decline in kidney function with an estimated glomerular filtration rate of less than 16 milliliters per minute per 1.73 meters squared of body surface area. And it happens over a minimum of three months, regardless of the cause. So it's not just diabetes that can give you chronic kidney disease. Hypertension can give you chronic kidney disease, autoimmune diseases like SLE, exposure to certain chemicals like lead, exposure to certain drugs like NSAIDs, recurrent UTIs, neoplasias, nephrolithiasis, systemic infections like sepsis, a family history, and a low birth weight. Yeah. So this is a quick pathophysiology of how chronic kidney disease happens. So in chronic kidney disease, when there's chronic kidney disease, there is a decrease in the number of functioning nephrons, right? So because of the decrease in the number of functioning nephrons, there's going to be the body is going to try and compensate for that. So there's going to be adaptive hyperfiltration at the glomerulus. And there's going to be an increase in glomerular permeability, and there's going to be an increase in the filtration of the proteins and the macromolecules. So there's going to be loss of proteins, and we've already established that if there's loss of proteins, there's going to be dyslipidemia, because the liver tries and compensates for that by producing lipoproteins, right? And then on this other side, there's the renin-angiotensin-aldosterone system that's going to be activated. And it's going to be activated as a way to try and compensate for the loss in terms of filtration. So this is going to result in an increase in the single nephron glomerular filtration rate, and that's going to lead to adaptive hyperfiltration. And if there's adaptive hyperfiltration, you have all this happening. And because of RAS, we know that there's angiotensin 2 that's going to be subsequently produced, that's going to lead to constriction of the vessel, that's going to lead to an increase in peripheral vascular resistance. And as a result, there'd be hypertension as well, right? And coming down here, we've already talked about how the mesangioblasts are going to start secreting the extracellular matrix and how we are going to get the sclerosis. So there's going to be tubular interstitial fibrosis and secondary focal segmental glomerular sclerosis. That's going to lead to, and this may lead to decrease in glomerular filtration rate, decreased urinary output, and systemic complications that we're going to see in a minute. Okay, so these are the complications, these are the effects of now chronic kidney disease. So because the kidneys are not able to carry out their excretory functions, the toxins are going to start building up in the blood, right? So you have urea. So when there's urea building up in the blood, there's going to be manifestations. There's going to be GI manifestations like loss of appetite, nausea, vomiting. There's going to be uremic pericarditis. So these individuals would complain of retrosternal chest pain that's pleuritic, worse on deep inspiration. Encephalopathy like a tremor, coma, death. There's going to be erectile dysfunction, decreased libido because of that. Again, the neuropathy. There's also skin manifestations like dry skin, pruritus, because urea is very irritating. So these individuals would complain of pruritus as well as ecchymosis. There's also an increased tendency to bleed because urea is going to it's going to impair platelet aggregation. So there's going to be platelet dysfunction, and that's why you can end up getting ecchymosis. And then there can also be a uremic frost in some cases. So these individuals' skin is going to be like whitish. Yes, there's going to be some whitish flakes on their skin. So because the kidneys are not able to excrete the potassium is going to build up in the blood, and there's going to be excess potassium that could potentially lead to cardiac arrhythmias. Renal osteodystrophy would result because, again, we know that you have the kidney that's responsible for activating the vitamin D, right? To change it now to 125 hydroxycholecalciferol so that it can go and absorb calcium from the gut so that you can have calcium in your body. So if this doesn't happen, you would have a decrease in calcium. So as a result, what would happen next is that the PTH, parathyroid hormone, would be activated, and it's going to promote osteoclastic activity that's going to cause resorption of bone. And so these individuals may have weak bones. And then peripheral edema, pulmonary edema, and hypertension would also ensue. There's also fatigue, a decreased exercise capacity, impaired cognitive and immune functions, as well as new onset heart failure. So all these are anemic symptoms, because again, we know that the kidneys produce the erythropoietin, specifically the peritubular cells of the kidney, right? So these individuals would, because they can't have their EPO, they don't have their EPO, they would present with symptoms of anemia. And at the end of the day, this is it's very taxing on the mental status of the individual. So it's very paramount to screen for depressive symptoms as well. So the diagnosis is made mainly based on the estimated glomerular filtration rate. And so it's multiple assessments over a period of 3 months ought to be done in order to confirm that the problem is chronic, right? So whenever you're taking estimated glomerular filtration, sex of the individual is important to keep in mind, age, as well as the weight, because it differs. So it has the G staging as well as the A staging. So there's the G1 to G5, and the lower you go, the more likely you are to get kidney failure. And so there's G1, whereby there's normal or high, more than or equal to 90 mL per minute, 1.73 meters squared. G2, it's mildly decreased at 60 to 90. G3A, it's mildly to moderately decreased at 45 to 59. And G3B, it's moderately to severely decreased at 30 to 44. G4, it's severely decreased at 15 to 29. G5, it's end-stage renal disease, and our patient was actually here with a GFR of 6, if I'm not mistaken. Yes. And then there's the A categorization that's been added to it as well. So in A1, it's normal to mildly increased if it's less than 30 milligrams per gram. A2, it's moderately increased at 30 to 299. A3, it's severely decreased, more than or equal to 300 milligrams per gram. So it's not sufficient to just use the GFR for identifying CKD, because again, we've defined CKD as an eGFR of less than 60, but stage 1 and stage 2 are above 60. So maybe they might be having a normal GFR, but maybe there's an underlying kidney problem that could potentially progress to chronic kidney disease. So for such individuals, the presence of one more of the following markers can help now establish a diagnosis. So albumin excretion of more than 30 milligrams per day, or an albumin to creatinine ratio of more than 30 milligrams per gram. Urinary sediment abnormalities can also be looked for. So maybe there's some red blood cell casts in the urine to indicate some glomerulonephritis, and so on and so forth. And then there's also electrolytes and other abnormalities, because that's going to tell you that the kidneys are not doing their job well. And then there's the histologic, despite having within normal range GFR. And then there's also histologic abnormalities, structural abnormalities detected on imaging, as well as a history of kidney transplantation. So for the labs, a complete blood count is indicated because, again, we've said that these individuals are prone to anemia, so a HB would be very important. A basic metabolic panel whereby the urea, the electrolyte, and the creatinine, as well as the calcium and the phosphates are well assessed. Then a urinalysis would be also paramount to do, a serum albumin level, as well as a lipid profile, because again, the concept of the liver wanting to compensate because of that hypoalbuminemia that's going on. And then the special tests, the other special tests that can be done in order to find out the cause of chronic kidney disease, you can do an anti-nuclear antibody, whereby you screen for SLE, because systemic lupus erythematosus can also give you chronic kidney disease. Serum complement levels may be depressed with some glomerulonephritis. and anti-glomerular membrane antibodies could point you towards Goodpasture syndrome. Imaging studies, so an abdominopelvic ultrasound could be done to screen for hydronephrosis, any fibrosis or a tumor. And a CT scan is useful to better define the renal masses and the cysts that's now been seen on ultrasound. And a CT scan is actually most sensitive test for renal stones. An MRI is indicated for those who require CT but can't receive an IV contrast. A renal radionuclide scanning is useful for screening renal artery stenosis and it can also help in quantifying renal contribution to the glomerular filtration rate. A biopsy is diagnostic, especially for those with nephrotic syndromes. Okay, so for the management is mainly aimed at halting the disease process. So early diagnosis and treatment of the underlying cause or instituting secondary preventive measures, like you tell the individual to stop smoking if they're smokers, or you encourage a change in diet. And then you would also treat the pathologic manifestations of chronic kidney disease. So if it's anemia, when the HB is less than 10 grams per deciliter, you treat with erythropoiesis stimulating agents like epoetin alpha. After now, iron saturation and ferritin levels are at acceptable levels. And then there's, for the hyperphosphatemia, that would be caused again because of the resorption of the bone because of hypocalcemia, right? So you treat with dietary phosphate binders and dietary phosphate restriction. The hypocalcemia you treat with calcium supplements with or without calcitriol. For the volume overload, you would treat with loop diuretics, and the metabolic acidosis, you would treat with oral alkali supplementation. The uremic manifestations, so these individuals can be taken for a hemodialysis or peritoneal dialysis. But at the end of the day, a kidney transplantation is the best shot that these individuals have. Thank you.
Thank you very much, Ruqayya. That was a very good presentation. Okay, so now Dr. Ahmed Tahir, Dr. Ahmed Sokwala, the floor is yours to critique or add anything.
Okay, let me start because I might have to leave. So very good detailed discussion regarding this case. Maybe I'd like to hear how our patient was managed because I think the first presenter stopped short of discussing what treatment the patient was given and how the patient was subsequently managed. Regarding this presentation, I think it was very good. Maybe we should have focused more on diabetic kidney disease and rather than be very wide, because there were a lot of aspects that were discussed, including diabetic foot and other complications of diabetes. So when you're given an opportunity to present a topic, you should focus on what the topic you are given or what your patient is suffering from. So this patient clearly had diabetes with CKD stage 5, and I would have liked to hear more on diabetic kidney disease, how to slow down its progression, and once a patient reaches such an advanced stage of renal disease, what options they would have had. So there was an attempt at that, but maybe something more detailed would have been possible if you had started the discussion or if you had focused earlier on diabetic kidney disease rather than to try to cover the whole of diabetes and then narrow down to some of the complications, and then at the end, yeah, so maybe can we ask the first presenter, how did they manage this patient? Because we need to learn with the patients we encounter. So here you had a patient, young male, poor glycemic control, and 10 years diabetic, and developed end-stage renal disease. So how did you manage this patient? Can we hear from the first presenter?
The patient is currently on dialysis. He's currently on dialysis, and he's continuing with his metformin regularly and together with the antihypertensive drugs.
Again, I'll comment because I'll allow Sokwala to come in later and finish up. When the patient develops a GFR of less than 30, metformin has to be withdrawn because it is being associated with lactic acidosis. So if this patient is still on metformin on dialysis, you need to withdraw. Then what I'd like to have heard is, said this patient is also hypertensive. One would like to know which medication they are on. And as you've heard from the second presenter, complications of diabetic kidney disease is anemia. So you want to know what's the HB, what type of anemia are we dealing with? Is it an iron deficiency anemia? Is it a macrocytic anemia? So you'd have liked to hear from that. You heard the second presenter talking about calcium and phosphate issues. So you'd like to hear from the first presenter, how did you manage, we call this bone mineral disorders in chronic kidney disease patients. So how did you manage this bone mineral disorders? These are the calcium, phosphates, parathyroid hormone, and yeah, then the fluid balance, you heard that I'll restrict the fluid. So in your patient, how did you manage the fluid aspect, the nutrition? How did you manage the nutrition of your patient? So then if you gave us all that, then the discussion would have been very valid because you would be discussing very pertinent issues regarding this patient of yours who's now on dialysis. So I'll allow Dr. Sokwala to make a comment or to comment, and then I'll ask him to take over the discussion and continue. He's a very able nephrologist who will be able to continue with the discussion. Dr. Sokwala, maybe you can mention a few things and continue the discussion.
Okay, assalamu alaikum. Sorry for, I couldn't unmute my mic. So yeah, thank you. Well presented, both the case as well as the presentation about diabetes and its complications. So as we all know, diabetic nephropathy is a microvascular complication, and our case in hand, most likely diabetic nephropathy. But when you're presenting in your history, you didn't really point to other microvascular diseases. You said something like he had a blindness. Probably that could have been eye manifestations of probably retinopathy, as Dr. Twahir mentioned, or retinal detachment or non-proliferative macular edema. You mentioned that there was no sensory loss in the lower limbs. There was no hair loss. There was no erectile dysfunction. I don't know if that's very true. Maybe you can go back and look at this patient and examine him a little more. So, when you don't have a lot of other microvascular diseases in this patient, then I start thinking whether is this really uh, diabetic nephropathy, or is it something else, right? And diabetic patients also get other problems which affect the kidney, like glomerulonephritis, as the second presenter mentioned. So urinalysis is very important. When you have blood, you have other RBCs, RBC casts, which show that this is glomerulonephritis and not only diabetic nephropathy. Diabetic nephropathy usually presents as mostly only proteinuria in the urine. So, urinalysis for this patient is very important. And, if you have 40% of patients with diabetes have other kidney diseases apart from diabetic kidney diseases. And if things are not fitting in with diabetic nephropathy, then it's pertinent to do a kidney biopsy to find out whether there's something else, like some other glomerulonephritis. Could it be membranous? Could it be, other, focal segmental glomerulosclerosis? And then the treatment changes from what diabetic nephropathy treatment is. Again, the mainstay of treatment for diabetic nephropathy, as earlier mentioned, you have to manage your sugar control very well earlier on. Avoid nephrotoxins. These patients, because if they get pain, they take a lot of NSAIDs. Avoid those nephrotoxins, and adjust the medications accordingly when your GFR goes down. Whether it is the sulfonylureas, whether it's metformin. As Twahir said, you stop the metformin when your GFR is less than 30. And the other mainstay, as you saw, the pathophysiology of diabetic nephropathy is stimulation of the angiotensin system. So the mainstay is treatment with angiotensin converting enzyme inhibitors or angiotensin receptor blockers. So that prevents your proteinuria and retards the progression of diabetic nephropathy. The newer drugs which are there, the SGLT2 inhibitors, I'm sure most of you have heard about it, and they have really shown to retard the progression of diabetic nephropathy. Again, used earlier, the better. When your GFR gets less than 20, then you stop them as well. So better sugar control, better blood pressure control, avoid nephrotoxins. Those three things would be your mainstay to prevent you to get into end-stage renal disease. And once you get into end-stage renal disease, obviously then, dialysis and transplant is the way forward. And, well explained about other issues like the hemoglobin, the calcium phosphate. You look at that, and treat accordingly, give erythropoietin, make sure you're giving your iron when a patient is end-stage renal disease, and make sure your calcium phosphate axis is okay as well. So I think those are the main things I would say, unless there are questions on the chat box, I don't mind answering if they're forwarded to me.
Okay, so we have a couple of questions. There's somebody asking you to comment on nutrition in CKD.
So yeah, nutrition in CKD. So, if a patient is diabetic, obviously you'll maintain your diabetic diet. And when you maintain your diabetic diet, avoid a lot of protein, animal protein, avoid salt, avoid things which would, if your potassium is high, avoid things which have high potassium, like some fruits, bananas, dates. The common myth is madafu is good for your kidneys, but it's not when you have CKD because it has a lot of potassium in it. So those are the main things to avoid in your diet.
Okay, one person is asking, can the diagnosis be CKD secondary to diabetes mellitus or diabetic nephropathy since the patient has all the signs and symptoms of CKD?
So, CKD can be caused by many things. So I don't understand the question really. This patient has had diabetes for 10 years. So probably it's just diabetic nephropathy causing CKD. And the only reason we were discussing is you didn't, point towards other microvascular disease on the history, or maybe he had, fundoscopy would help. If he had any retinopathy changes, then most likely this is diabetic nephropathy causing the CKD.
Okay, we have someone requesting you to expound more on the SGLT2 drugs.
Okay, that's a lecture on its own. I don't know what you want me to expound on. So the different types of SGLT2 inhibitors, what happens is they secrete, one of the functions of the kidney is to reabsorb glucose in the proximal tubule. The glucose transport is inhibited. So there's no glucose being reabsorbed. So glucose is excreted in the urine. And that causes the glomerular feedback, which causes vasoconstriction indirectly of the afferent vessel. Okay, when afferent vessel is vasoconstricted, the glomerular pressures go down. And when the glomerular pressure go down, the proteinuria reduces, and that helps the nephron itself to go into fibrosis, etc. So that's the simple mechanism of how SGLT2 inhibitors work, similar to the way the ARB or S inhibitors work.
Okay, can you kindly explain the relationship between hyperlipidemia and hypoalbuminemia?
So I think that question would go to you guys. Nephrotic syndrome, one of the things you see in nephrotic syndrome is, you get hyperlipidemia, okay? It's not hypoalbuminemia is not related to hyperlipidemia. That's the wrong thing. It's nephrotic syndrome related to hyperlipidemia. So what happens is when you lose protein in the urine, you also lose the lipoprotein, lipase, all the other proteins. And what happens is the lipids in your body, which are taken away from the vascular system and stored inside the liver, inside the adipose tissue, it's reduced. Okay, the lipoproteins are reduced. So because you've lost them in the urine, right? And that increases your lipids in the blood. I mean, that's a simple mechanism I can explain to you.
Okay, I think that's it for the questions. I don't think there are any more questions.
Okay, I think you guys.
You're muted. Doc, are you speaking? You're muted. Let me see if I can unmute.
Okay, no, I was just saying that you guys did a great job, and I hope it was of benefit. I'm sure it was for everyone, and you should continue this activities as sound, because this will really help you. And feel free to get in touch with us whenever you need us. And I can see a lot of Muslim medical practitioners here. So we have something called camp, and you guys should all be members of camp.
Yes, they should. We have Camp joining us in the meeting as well. Dr. Nabila, I think that's Dr. Nabila. Doc, there's one more question, if you don't mind answering. Could I read it out to you? there's someone asking you to, I don't know, let me see. Let me try to fix that. Okay, can you try unmuting now?
Yeah, looks like somebody likes muting me. So yeah, sure, I can answer that question.
Okay, so somebody's asking you to touch on preemptive and live kidney transplant.
Yeah, so in this country, we only do live kidney transplants. That is, and related kidney transplants. So you have a donor who is a living donor, and you have 2 kidneys. You can donate 1 kidney, and you can live a normal, healthy life with 1 kidney. Some people are born with 1 kidney, and as long as you live a healthy life, then 1 kidney is enough for you to, to carry on with your life. So we do live related kidney. That's 1. 2, preemptive transplant means that when your GFR goes below 15, then you think about getting a transplant before you go into dialysis, which we do it here as well. I've done a couple of preemptive transplants. And so, it's actually shown to have a better outcome than when you are on dialysis for 6 months, a year, and then you think of a transplant. So that's what preemptive transplant means. So you do a transplant before you start dialysis. So when your GFR gets to 15, 10, you get a transplant done.
Okay, I think that's the last question. The next question is for Dr. Nabila. There's somebody asking how to join camp.
Okay, so if you don't mind, can I leave? I need to rush for my prayers.
Yes, you can. Thank you very much, Doc, for
All right,
joining.
shukran, jazakallah.
Jazakallah khairan.
Yeah. Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum salam wa rahmatullahi wa barakatuh.
Actually, Dr. Ahmed Sokwala is the convener of that committee, membership committee, and he's just left. But before I get to that, I just wanted to emphasize on the relationship between a chronic illness, and now that we are talking about diabetes, and depression with anxiety as well. Yeah, I'm happy that Rukia mentioned about that. Of course, being a chronic illness, there's a lot, going on. Your life changes drastically. You're told now you can't eat this, you can't do that, you have to do this, you have to take your medications on a daily basis. You don't know what will happen because there's a lot of complications as well, coming with this condition, like we've just seen. So I want to emphasize that we really need to rule out depression and anxiety in such patients. I don't know whether we did that for this specific patient. If not, we should. And I think it's important as well to involve a psychologist in the management of this particular patient. Of course, it's not a must for us to start the patient on any medications in terms of antidepressants or anxiolytics if the severity is not requiring medication. So I think if Nani Rajiv, you haven't involved, or the team hasn't involved a psychologist, let's do that. And if the patient requires a psychiatrist to be on board, then that's also important. Okay, so I just wanted to emphasize on that. Being a camp member, if you want to be a registered camp member, there's a subscription fee of 500 shillings. This is an annual fee, and we can share the poster, which just explains how to go about it. It gives you the different categories. And students are also there. So if you want to join, you can join in that way. I can also share our secretary's number. You can contact her. But what we are doing now is, already interacting with camp, and we are going, inshallah, to introduce mentorship programs as well. So yes, we are always there to support, as Dr. Ahmed Twahir mentioned initially. Back to you, Ayan.
Okay, perfect. Thank you very much, Dr. Nabila. And thank you everyone else who joined us today. I think both of our consultants have left the chat. Jazakumullah khairan for joining us. Inshallah, we'll restart the sessions to be every week. So if you have any case that you'd like to present, you can approach Mohammed Jamal or any Msaun committee member that you know. And Dr. Nabila has posted a number that anybody who wants to join camp can contact. Thank you very much, guys. Inshallah, until next time.